Thank you. Hello, everyone. I just wanted to say hi myself to everyone who's joined today. Thank you for being part. And I'm grateful to Cognitive Care Solutions for making this opportunity available. And I think it's important to give a nod to Cognitive Care Solutions because we are blessed to have them in our close vicinity, because Parkinson's, and especially in the realm of movement disorder, is one of the few areas that require the full spectrum of different types of therapy. I didn't even realize there were so many different types of therapy when I first got into this particular field that really benefit Parkinson's. But if you think about it, from memory to physical to fine motor skills with the hands and speech therapy, really these four main branches of therapy are all equally important. And you could even throw in psychology and cognitive behavioral therapy into the mix as a fifth group. And really, Parkinson's folks all can benefit from that full spectrum. At different times, really, it comes into play. And so, really, this is the kind of main area within neurology that you can see that interplay between the different non-medication therapies. Obviously, I'm going to be talking to you a lot more on the medication end of things, but you and I are always trying to figure out when to weave in these non-medication interventions to make a difference in your outcomes and care. And so I'm grateful again, because we are all blessed to have a good group who actually focuses on that, and very few other places I've ever worked have that advantage. And even in the time post-COVID, when we can do some of this telehealth, even more of an advantage, unless our senators and congresspeople don't get their act together. And I encourage all of you, and you are the folks who actually might write a letter or send an email to a congressperson to get them to open up the government again. We all would benefit from that in terms of helping maintain Medicare telehealth availability. So I'll just put in my little plug for encouraging our elected representatives to do right by all of you. All right. So I've just not this last weekend, 2 weekends ago, I came from the International Movement Disorder Society's meeting. And that meeting got to review a couple things that are really focused on the future in this regard. And really, that's what our talk is focused on today. It's sort of apropos that it's the last talk of the year, which is current research and future treatments in Parkinson's. And I can reveal at least what looked the most promising rather than what's purely theoretic that kind of came out at that discussion this year with all of you. So for those of you who are new to Parkinson's, this is really talking about either things that are into the advanced level of when people start to have motor complications, and what we found seems to decrease that, or a lot of the non-motor symptoms connected with Parkinson's, things that range anywhere from memory to anxiety, depression, sleep disturbances, autonomic disturbances like low blood pressure, dizziness. A whole host of different non-motor symptoms can occur with Parkinson's as other neurotransmitter deficiencies begin to take hold. And so really today's topic is really focused on a lot of these other advanced issues. Earlier topics that we brought up have really focused on the basics. This is kind of looking at more advanced approaches and customized approaches that might not be something that every single one of you is going to need, but it's good that we're advancing our knowledge. And when working with a movement disorder specialist or team, they can really help you customize some of these approaches I'm talking about as they either become available, or some are available now that really have decreased the complication rate as time has gone on. So the first thing I'll talk about is advances in research, really looking at risk factors for the disease itself. And so one of the ones that was really, gave us quite a bit of good insight at the Movement Disorder Society conference was really looking at the environmental exposure of pesticides, and not just one, but sometimes multiple exposures seem to be causing some of these clusters in our country and in other countries of where Parkinson's is occurring at higher rates. There's been a lot of talk in the Rust Belt around sort of the Michigan, Detroit region of the Great Lakes region. There seems to be a cluster with higher incidence of Parkinson's. And in the Central Valley of California, closer to home, there's been a higher risk. And we've really seen that with, a multitude of pesticides that seem to increase the risk of Parkinson's. But obviously not everybody gets it in that particular region. And so they definitely started looking at, when we talk about pesticides, that's a whole group of different ones. And the highest risk were really with a group called the fungicides, the ones that kill off fungus on the crops, and another group called the organophosphates. So these seem to be the ones with the highest risk of exposure. These are usually workers or those who are in close proximity to spraying of the fields seem to be at the highest risk. That risk being about 2 times the risk of the general population. So notice that isn't a 100% guarantee. So there just seems to be a somewhat higher risk. What explains that is we think that there are folks with, they might have a genetic risk with it. And that's where really research has been looking at is folks who might have 1 copy or 2 copies of a gene that increase their risk when they come into contact, demonstrated by my pen, with the appropriate or inappropriate pesticide. And so you have to have the genetic risk and the pesticide exposure to really be at this 2 times risk of developing Parkinson's compared to the general population. 1 copy of the gene may only increase your risk a little bit. 2 copies of it might be much higher. But if you don't get exposed to the pesticide, even with the gene, you would, be at normal risk for the population. If you don't have the gene, but you're around the pesticide, then you also won't generate the risk of Parkinson's. So that's why it's not as clear cut, and we really haven't been able to understand it as well until these more recent extensive studies have looked at kind of what seems to be putting these populations at risk. There are even certain gene risks, for instance, that would increase that risk from 2 times risk to about 4 to 5 times the risk in folks with, certain variants. There was even another subgenetic variant of a gene that put people at almost 10 to 40 times the risk of Parkinson's. Still not a guarantee, but I just wanted to be able to explain that to people. Oftentimes since we're talking about genetics, we also worry about, oh, well, if my family member has Parkinson's, what does that put my risk at? And that risk is, somewhere, probably between, if, normal risk in the population is 1, people with a family member, like 1.2 to probably 1.4 risk, higher than the general population. So it's a little bit higher, but it's not a guarantee. And that's important to tell your family members about. And that was kind of one of the more interesting discussions that they had. One other interesting point that they brought up is clouds are probably a neglected source, especially in Europe. They found that clouds in France might bring pesticides to then drop on other parts of Europe that then puts them at higher exposure. And one other risk factor in the environment was they did find that air pollution, specifically particulate matter, seemed to increase the risk of Parkinson's by about 60% higher. So, so that would be sort of like a 1.6, risk in terms of it. So these are the types of things that, might have, increased all of our risks of exposure depending on where we grew up and where we lived throughout our lifetimes as both children and adults. Okay, so that was just something I wanted to relay as a lead-in. Another thing that was interesting at the conference was there's been a greater focus really on gut health. And I can only give you so much that we know, but we all know that many times the disease of Parkinson's starts in the nerves, and that we think that inflammation, possibly pesticide exposure, and possibly even if you've had any other major GI inflammatory disease, irritable, like inflammatory bowel disease, or gut surgery, any kind of abdominal surgery. All of these things seem to put people at higher risk of Parkinson's because that inflammatory or physical or surgical trauma seems to sometimes increase the risk of the formation of the bad, damaged alpha-synuclein protein, where that protein might be in the shape of my hand, and then it gets damaged into the shape of my fist, and now it doesn't get broken down. And all of those inflammatory, toxic traumas there can increase the risk of that bad protein formation. And it spreads from the nerves of the gut up the nerve called the vagus nerve into the brainstem, and then spreads from the bottom of the brainstem called the medulla up to the top of the brainstem. And when it starts to kill off those dopamine nerves, that's finally years later, approximately maybe 5 to 15 years later, it starts to finally damage enough dopamine nerves that then the motor symptoms of Parkinson's appear. But in between, and then later in the disease, it can affect other neurons, causing symptoms from, sleep disturbances, memory problems, and greater motor complications and non-motor symptoms over time, such as, for example, say low blood pressure. Oftentimes I'll tell my patients, hey, a lot of your low blood pressure phenomenon is oftentimes damage to the sympathetic nervous system, the part of your autonomic nervous system that regulates your blood pressure, and it doesn't work as well, and your blood pressure starts to drop over time. And so a lot of that has been backed by research that has shown that, over time, we, your movement disorder neurologists, really need to be on the lookout of when to start pulling medications away from even meds you've been on for sometimes 30 years for high blood pressure. Suddenly, the Parkinson's damages the nerves and you don't need those high blood pressure medications anymore. Your greater risk sometimes becomes low blood pressure. And so that's oftentimes challenging for many physicians. All of you would make the argument that physicians are really good about adding medications when you have a problem. We are not as great at knowing when to pull medications away and simplify your regimen. And that's really where the neurologist helps to advise the primary doctor and the cardiologist and a bunch of other doctors of when we need to pull medications away that have been shown to either cause more weakness, such as statin medications, or balance problems, also statins, but sometimes certain antibiotics can damage your peripheral nerves and worsen the balance. That's one of the advantages that my practice has been able to provide people, because we don't just look at the movement disorder, but we look to see if there's any other neurologic issues like damage to your peripheral nerves that can set in over time from the Parkinson's or from exposure to diabetes, thyroid problems, vitamin deficiencies like B12, or exposure to certain antibiotics like Cipro or Levaquin, or certain cardiac medicines like amiodarone. These are all things that were pointed out in the research that increase balance issues as separate neurologic issues that kind of magnify the Parkinson's. So the other thing that was really focused on was data has continued to show over time that aggressive treatment of the problems of constipation with agents like Miralax or its generic equivalent that keep the gut moving proactively really has been helpful for both decreasing the discomfort and of constipation, but also helping with promoting absorption of especially the generic versions of Parkinson's medicines. That being said, over time, we have found that a lot of these long-acting carbidopa-levodopa medications like Rytary over the last 8 years, and a medicine like Crixant, another really good long-acting, well-absorbed version of carbidopa-levodopa, has really, both maintained how well levodopa was working for people as it turns into dopamine, but also really simplifying people's regimens like dramatically. And so a lot of what you read on the internet about, oh, motor complications of Parkinson's and the medicines like carbidopa, levodopa that are used to treat it, really, gosh, we've been able to eliminate so many of those and maintain the viability and how long carbidopa, levodopa can work for people by utilizing these better absorbed, better constructed and manufactured versions that help with absorption, really maintaining and leading to fewer problems and fewer motor complications. And when I think motor complications, you guys always think Michael J. Fox, right? He has a lot of dyskinesias and extra movements, as well as he goes off, really, where he gets fairly immobile fairly dramatically. And those are, if those occur, if we are treating people like it's the 1960s and 1970s, with the generic versions of carbidopa, levodopa, those can occur more often. But your movement disorder specialist really can move you to an advanced long-acting agent that really dramatically eliminates a lot of these fluctuations up and down, on and off phenomenon that are happening. And that's been great. I've been very grateful to see that kind of longer term data that's really proven that if we get around these absorption problems in the gut, you don't build up resistance to the medicine. It's really mostly your intestine is not absorbing this consistently over time. And thankfully, modern technology has enabled us to improve that absorption. Staying focused on the gut for just a second, there's also, now again, this isn't quite 100% ready for prime time, but there's been prolonged looking at trying to improve the function of the gut, whether it's the bacterial milieu and flora of bacteria that exist in the intestine to help the intestine do this job of absorbing better. That can be fiber and prebiotics and probiotics. And they're trying to really search for that, perfect mix that really is helping folks over time. I actually saw a name, and I meant to capture it for you guys, and I'm going to find it. Oh, here it is. I want you all to look up something called neurofiber. Neurofiber. I'm going to put it up on the screen and see if you can see it. So, whoops, here it's a little too small. There we go. So this was a group that was at the MDS conference called Neurofiber. And so they were really trying to use whatever the current active knowledge is about how to promote good gut health. And that seemed to be reasonable. I have not yet used this in my patients, but it has just become available. That's one that looks, potentially promising. It's trying to pull a lot of the data from multiple studies looking at the gut, trying to put it into kind of one mixed ingredient. That's really, all of this is really non-prescription. This is really all supplemental based. And I think very few of your providers, whether in movement disorder or general neurology, would be really, they really wouldn't be concerned, about you continuing to use this. This may improve problems with the gut and trying to improve that function and absorption of the gut for as long as possible. And that looks very promising. Maybe next year I'll be able to give you some practical experience with that, but that was at least one company that's trying to bring a lot of those data points into an actual product brought to market. So there you go. At least I've let you guys know. We'll all be sharing that information. If any of you try it, share that knowledge and experience amongst yourselves if you're noticing any improved absorption of your medicines or just better gut function and less constipation in general. Okay, so I wanted to make sure I focused on that a little bit. And also, as we're talking about longer acting versions, now this is really less research, but it really shows the advantage of a lot of the research that's been brought to market has been, well, what if you have problems absorbing it? What if none of these other clever ways of getting the gut to absorb it has really made a difference? And that's really where we can sometimes avoid the gut entirely, and we can use a pump device. Now, this is one called the Vialev pump. and this is delivering carbidopa, levodopa directly under the skin. So this is a pump device that's on the external, right? It's outside your body that you carry with you. Usually you'll carry it, on your hip or um, on a like a crossbody kind of sling, and the medicine gets pumped out the bottom and it gets activated with a simple button and activation. And we can usually set it, and it's been very helpful this year and has become available to our Medicare patients as well as all of our younger commercial patients, that it's been relatively, even our HMO patients, we've been able to get this as long as we can document the need and the fluctuations and wearing off that you're noticing. That pump, it delivers the medicine. This would be an example of your skin, and there's a little stamp that we use that will apply this little device to the skin, and this is what it'll look like. It'll just be this slightly raised device, not very high. The profile is pretty low, and that would go on your skin. And there's a tiny little. Let me show you under the skin. There's a tiny little tube. Let's see if I can show you with the camera here. It's a tiny little tube under the skin that's delivering that medicine subcutaneously. And the medicine is carbidopa, levodopa, right? The good stuff that turns into dopamine. And this is what you would see on the top of the skin. And there'd be a little sticker, a little Band-Aid that keeps it adhered in place. And the brown is meant to represent your skin. The green is just a frame that this is held in. But you can apply that every day, and this pump works continuously. This has been by far and away the most effective device to really simplify people's medication regimens and improve on time and eliminate a lot of freezing motor complications. So I've been very grateful to see that. Now, obviously it's not perfect for everybody, but gosh, we've had probably like an 80 to 90% success rate in really tough, complicated patients at improving their function and on time, in the patient's opinion, not just the physician's opinion, but in the patient and the family's opinion. Now, that little tubing I showed you just, connects to the pump device, just like that. And it can be easily disconnected as well. And so this pump just works throughout the day and throughout the night. And it eliminates the vast majority of the pills that we're using. And boy, talk about sometimes bringing patients, significant relief and liberation. That's really achieved it. While I'm talking about the pump devices, now again, this is my impression, you guys, and I've actually told the companies to do some additional research with this, but this has been so effective that, and I've had 2 patients in the hospital for other reasons this year, just within the last 6 months. They've had to go in for like one was a hospitalization for an infection and sepsis, and the other was a hospitalization that they had a planned orthopedic surgery. I think it was a knee surgery, right? Knee replacement. And they received their pump device in the hospital. And if any of you have been in the hospital, you all know that administration of your medicines can be tricky in the hospital. The nurses cannot always replicate how you and your loved one are administering the medicine at home, especially those with complicated regimens. And boy, this device, being able to use that in the hospital really simplified their regimen. The person with sepsis got out of the hospital probably at least 2 to 3 days before they would have, because they were immediately able to get their regimen. They stayed mobile and they were able to work with physical therapy right away. The other patient, post-operatively, most Parkinson's patients, they have a real tough time with orthopedic surgeries, whether it's the spine, the shoulder, the hip, or the knee. And almost predictably, Parkinson's patients will take 2 to 4 days longer in the hospital because they get so stiff and rigid. Their med regimens aren't always optimized. Like in general, they just, the orthopedists know they have a harder time getting going post-operatively. My patient got out at the exact same time as all the non-Parkinson's patients. She was able to get up and do PT and rehab and walk day 1 because they were wise to administer this pump. Now, this is I don't want to overblow this, but if I were making these types of decisions at the Medicare and at the hospital level, shoot, you guys, ever since I've seen this, and I mean, this is my case of 2 cases, right? It's not a 100 case or a 1,000-person case, but if it were up to me, I would have everybody with Parkinson's get one of these connected on you in the hospital. It makes the nurse's job easier. It makes your rehab easier. And I really feel like the company, AbbVie, that manufactures this needs to do a study to prove to Medicare and the insurances that you all do better and get out of the hospital quicker and rehab faster for all of these orthopedic interventions, that it should almost be the standard of care when administered in the hospital. And remember, now we have a device that can deliver medicine under the skin. So let's say you're in for like a GI problem. Like, what if you had a gallbladder or an appendicitis issue? You can't eat anything, which means you guys are all stuck not taking any of your Parkinson's medicines, which is like a nightmare in my mind, neurologically, because I can't use anything by mouth. Finally, we have something that can work in an alternative pathway, that when you can't take anything by mouth, you can still get your Parkinson's meds. And if this gets studied, and it should be, this will allow for shorter hospital stays, quicker return to home or return to rehab, and at least being able to get out of bed instead of being stiff and frozen. Anyway, that's me being on a pedestal, that I really feel like this is the advancement that should become almost, a matter of course for everybody in the hospital. And that can usually be figured out within that first hours, that we can do a pretty reasonable conversion from whatever your home regimen is to what the pump should be doing. So that's me getting a little ahead of myself, but that's really what this talk is about, you guys. Like, how can we optimize your care? Even if you don't take the pump home, like, how can we do a better job of caring for you in the hospital? Because, admittedly, Parkinson's care in the hospital is mediocre. It's never going to be as good as what you all can do at home. I know that, you know that, your loved ones know that. Okay, so that's me getting a little excited, because now I suspected that, but I didn't really talk about it. But now I have 2 cases that I'm 100% convinced I was right about this. And I have talked to the company about that study should be done at least in a retrospective analysis, if not prospective. There is a second device that came to market. This is another one of those devices, kind of same subcutaneous little delivery of it. And this is a separate pump that we use for apomorphine. So it's the apomorphine pump. And so this one can be used in the daytime as add-on therapy for really improving motor function and off time. And so again, a little smaller device. Still, you'd carry it next to you and still delivered under the skin. Apomorphine has been a long-standing dopamine agonist medicine that we know works and is especially good for off time. We only had it in an injectable format, and now we've got it in a pump continuous delivery format. And so this is nice when, patients respond better to it. These are both good pumps. Both have been shown to really improve off time and, potentially impacting things like freezing and just decreasing all of these motor fluctuations that are happening because your dopamine level has been fluctuating. Okay. All right. So those were kind of like both things that are now available, right? We are now able to use these, but also some of my view of the future of how it's going to impact your care on a daily basis. What's the downside to the pump devices? Really just, you have to carry a device, and as liberating as it can be, you still have to have a device with you in a little fanny pack that you put on your waist or across your body. Obviously, it's an infusion under the skin, and so we always have to watch out for any signs of infection or sometimes even just inflammation, but we really can decrease that by moving the site around. And so on the person's abdomen, we'll do it in different sites. Or sometimes on the upper leg, we'll do it in these different sites and move it around to decrease any signs of inflammation or nodules or anything. We're trying to decrease that formation. But it has been, like I said, revolutionary, and all the movement disorder teams in the county have really been utilizing this effectively. And we've been really excited to be able to offer it. Is it for everybody? No, right? Like, I would not offer this early to a patient, but to be able to have it to go to has been immensely beneficial. But using long-acting, oral medicines like the croissant, really, right, it really eliminates a lot of these other peripheral, non-essential medications. It decreases the formation of the motor complications in the first place. Convincing insurances of this, of course, we have to continue to build that data, but that's really where we've seen it with Rytary and now croissant. And, I expect us to continue to be able to gather more data about that as we go forward. Okay, that's kind of my big focus on the dopamine agents. Now to look a little bit more in the future, and this one I'm going to talk about another dopamine agonist medicine that's really going to be FDA approved and going to be available in the springtime, maybe at latest by next summer. And it's a long-acting dopamine agonist medication that kind of looks like dopamine, called tavapadon. Tavapadon, I'll spell that for you. Tavapedone. So this is a good medication for patients. Dopamine agonists are medicines that stimulate the dopamine receptors. Some of you are on or have been on other dopamine agonists that stimulate the D2 and the D3 receptor, D for dopamine. And those are medicines like pramipexole, ropinirole, or the patch medication Nupro. These are all D2, D3 dopamine receptor agonists, meaning they bind to those dopamine receptors. And they act a little bit like levodopa, carbidopa, levodopa, and turning into dopamine. They're a little different. Sometimes they're a little longer acting. Historically, all of those dopamine agonists have been helpful and good for things like refractory tremor, and they help with wearing off. But we have had compulsive disorders associated with them, like obsessive compulsive disorder, or compulsive shopping, compulsive eating, even compulsive like sexual impulses or impulse control disorders. And while those are not terribly frequent, they are a concern with the older group of medicines. However, tavapadon is binding to different dopamine receptors, the D1 and the D5 receptor. And so we're hoping we're going to get different, less of those impulse control disorders, but still providing kind of this other augmentation to the dopamine effect to keep you mobile and really help the motor and non-motor symptoms. So that looks very promising from that perspective. And that looks like it's going to be relatively easy to add on and very long acting. And so almost all your movement disorder specialists are going to be looking at utilizing it going into the new year. So I was just letting you all know that one would probably be add-on therapy. It probably won't replace carbidopa, levodopa, Sinemet, but it can really augment its effects or help maybe some refractory symptoms that the carbidopa, levodopa is not treating. Okay, so that looks very promising. That one's ready for prime time. It's on the launch pad and should be available to us next year. Okay. Now I'm going to talk very briefly as I get to the end of my talk part of the session, and then I want to answer questions, really looking at some old medications that may come into play. Some of you may notice as the disease goes on that those compulsive disorders can either occur as a result of the medicines or as the result of the disease itself, and people can get something called Parkinson's psychosis. Psychosis is defined as either hallucinations, that could be seeing things that other people don't see, hearing things like voices or sounds, or feeling things like bugs crawling on me. These are, or I even had one patient felt like another person was crawling into bed with them. They couldn't see the person, they couldn't hear the person, but they could feel the person next to them. That's an example of a tactile or sensory hallucination. Okay, so that hallucinations can be psychosis or delusions. Delusions are fixed false beliefs. A delusion would be like a delusion of paranoia, like somebody's out to get me, or somebody's stealing my money, but nobody's stealing your money, or just these fixed false beliefs. Now, that could also be, oh, my grandmother's coming to have lunch with me today. And if I said that, but my grandmother had passed, my grandmother's not coming to lunch, but that's a fixed belief. Now, sometimes your loved ones can convince you, no, 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 remember she passed away. And then you're like, oh, okay, you have insight to the facts that it's a fixed false belief. And sometimes it's hard to convince your loved one that that's not happening. So that's Parkinson's psychosis. And we've had Nuplazid that we've used on label, and we've had to really block those sensations. Off label, we've used the generic version of Seroquel called quetiapine. But in the future, in the near future, we may use an old medication called clozapine. Now, most of you haven't heard of clozapine, but clozapine is the most powerful, most effective, and arguably the best tolerated of all of the antipsychotic medications. But it hasn't come into common use because its only FDA approval was for schizophrenia. And it is not going to worsen your Parkinson's symptoms. If I could give it to Parkinson's folks easily, we would. But clozapine had a lot of very tight regulations around it because we had to do a lot of blood testing on people. And so we have new research that really says, hey, we don't have to do this blood testing every week or every other week for life. We just really have to do it for approximately about 6 months in most people. And that may become a revolutionary medicine that would allow us to treat psychosis of all types, but specifically in Parkinson's. It is proven to be the safest of the antipsychotic medications to treat hallucinations and delusions, agitation, those types of symptoms associated with Parkinson's psychosis. Now, only a small fraction of people are going to encounter that, but it would be great if we could bring this medicine back into more common use. And as long as you all realize, well, we may have to do some blood tests fairly regularly for a period of time, but after that, we'll be able to really liberate you from most of the blood testing. That's really good news. Yeah, so what is old can be new again, but it's also going to be cheap and cost effective as long as we can access it, because there's really a move going on right now to move that into more common use. Okay, and the other thought I'll mention very briefly is also looking at using medicines in Parkinson's that come from other areas of general medicine and other areas of general neurology, which is what our team is really good at, is really looking at ways to treat problems like low blood pressure that can really cause cognitive issues when your blood pressure drops, dizziness, fainting, and falling. And that becomes an area where we're really treating these dysfunctions in the autonomic nervous system that can kick in late, sometimes early, but usually late in Parkinson's, and pull away meds that aren't needed, but then use medicines that raise the blood pressure. And those meds come from a weird assortment of areas, from medicines from cardiology and primary care doctor to raise the blood pressure. Sometimes we'll use the mild stimulants that we use in kids with attention deficit, like Ritalin. Sometimes we'll use migraine medications. Interesting enough, even though you don't have migraines, but I do have a few different anti-migraine medicines that keep the blood pressure from dropping, because so many of you eventually get problems with drops in the blood pressure. So this gives you a little bit of a hint of these things, or even combining old medications together to try to get help with complex problems like dyskinesia. dyskinesias like the Michael J. Fox extra dyskinesia, we combined a migraine medication with an anti-anxiety medication called buspirone and zolmitriptan. And we've had some good fortune at being able to help people sometimes treat their dyskinesias. This is an off-label use, but it's one that's been studied, and that was presented at the Movement Disorder Society meeting. Also, we know some of the antidepressants can sometimes help us with freezing and off periods. And there's a medicine called Trintellix, which a lot of the movement disorder doctors will use. And its specific medication profile and what receptors it targets seems to sometimes help with the freezing phenomenon. So a number of you may already be on it, or if you encounter that side effect, that's one of the off-label meds that are currently available, but we've seen a new use for it. Okay, so that's a little bit of my current summary this year of things that are really either available now or very soon to be available that really have revolutionized our ability to treat this as complications and issues arise. So I'd like to open up the floor to additional questions, things maybe you've heard about that I might or might not be able to comment on if I have some insight. And so I'm opening the floor to questions. Allison.